Good morning, everyone. Welcome to we have one more week left of MHAM. It feels like June has just been a blur. I don't know about you, but it's been so crazy.
It's been
So
exciting for headache advocacy, that's for sure.
we have had the best feedback and people just saying they love the lives. And so we actually got Dr. Starling to be part of our live with live, really live today. So I'm so excited to have you, Dr. Starling, here as we talk about discrimination and migraine. And tell people a little bit about where you practice, what your background is.
For sure. So my name is Amaal Starling. I'm a headache neurologist at Mayo Clinic in Scottsdale, Arizona. I'm really involved with the American Headache Society, as well as the Alliance for Headache Disorders Advocacy, and of course with AMF as well. I'm really passionate about empowering the entire headache medicine community. That includes the patients, the caregivers, but also clinicians, right?
Yeah.
Clinicians really need to be empowered as well to understand how easy it is to actually diagnose and get people started on the pathway for treatment. But we're here to really talk about the patient experience.
Right.
So let's dig in.
Yeah. So tell me a little bit about a couple of different types of discrimination. Like, is it just racial? Is it females? Is it males? Like, what do you think is still kind of looming in the migraine space?
Yeah. So I think what's really important about a lot about migraine is that it happens in an invisible space,
Mm,
right? And that includes the discrimination.
mm.
The discrimination is actually not often loud and obvious, but rather that discrimination occurs in a quiet denial of care,
Yeah. Yeah.
right?
Wow, that's powerful.
The discrimination occurs in a disbelief in the disease of migraine in the workplace.
Yeah. Yeah.
It occurs in silence in the systems that are in place. And so it's really important to work at all of those levels and try to bring all of those things that are quiet and invisible to light and talk about it in a way that we are really bringing justice to the forefront,
Wow.
right? This is not just stigma, but it's really about bringing dignity to this brain disease that people are living with,
Yeah.
right? And I think that's another piece, right? There's a lot of discrimination in migraine as a result of it disproportionately affecting women. There's a lot of discrimination in the fact that it is related to pain. And so I really like to move away from the pain piece, which of course is very a disabling symptom, but talk about the brain piece.
Yeah.
So I think that's one tip that I have or pearl that I have for patients as well as clinicians is talking about migraine, the brain disease,
Yes.
instead of migraine, a pain condition.
Yes. What do you suggest a patient does if they feel like maybe they're not being heard and they may say it's because of discrimination? What should they do when they go in and see their practitioner? And what advice do you have? So they were like, hey, wait, I need you to hear me on this.
Yeah. So, I can actually answer that question in a way that's driven by data
Mm.
and recent data that was kind of mind-blowing to me. So if someone asked me, why do patients come to see you in the headache clinic? I would say because they have a headache, because they have pain, right? The vast majority of the people that I see in my headache clinic have migraine just because of the high prevalence of migraine. And I would say all those patients come to see me because migraine is a painful, debilitating disease.
Right. Right.
The data from the Overcome study, which looked at 54 different factors to identify what are the most predictive factors for individuals seeking care, identified that it's the in-between attack symptoms.
Yeah. Yeah.
Not necessarily the pain symptoms, but the day-to-day symptoms that people have when they have migraine.
Wow.
It's called the interictal. Ictal is individual attacks, but the interictal burden is the primary driver.
Isn't that amazing?
For care-seeking behavior.
Wow.
And it has really changed the way that I initiate and approach that conversation. And I would recommend for patients, your doctors don't actually know that you're there for the in-between symptoms.
Mm. That's amazing.
Right? And so coming to them with not just talking about the attacks, not just talking about the pain, but talking about the full spectrum of the symptoms
Yeah.
that are disabling for you.
Yeah.
Right? The
Wow.
brain fog, the light sensitivity, the sound sensitivity, even when you're not in a migraine attack.
Wow.
Right? The side effects of the medications that you're given, all of those things are the burden that you have in between attacks. I think talking about all of those things can really help the clinician understand the full spectrum of what is disabling your symptoms and really, again, bring it back to this is a brain disease, not just a pain disease,
Yes.
right?
Isn't that amazing? I think I can't even imagine, and certainly this is not a statistic I could like guess, but I can't even imagine how many people are confused by that because, in our society, we've always heard of migraine as the headache pain, the headache pain. And what you're saying is that is actually not even why patients are coming. It's because they almost get to that point and I mean, it's awful. And don't get me wrong, but it's almost like all the other symptoms that no one's talked about is really where we've got to raise the bar and educate patients and providers. So that's powerful.
And you know what it is? I think often in my patient population, even though that is why they're indicating on a survey that that's why they're seeking their care. Number one, it may be that I'm not asking them in the right way about those symptoms, but it also is that often the patient does not offer those things to me unless I dig. Because now I've been trying to think about that more and I've been digging more. And I wonder, like, why didn't the patient tell me about that? And I think that reflects the discrimination and the disbelief that patients have had for so long. They don't want to talk about all the symptoms that they have every day because they feel like, oh, I don't want to be a complainer.
Yes.
Right? Let me just talk to them about their really bad days, right?
Yes.
So often patients will come to me.
And they feel rushed, not with you, but I mean with any provider, they're feeling rushed and like, I got a few minutes, I got to get all these things done.
Let me just tell you about the really bad days. So 2 days out of the month are really, really bad. I'm in bed, right? And often a clinician can be like, okay, so you've got 2 migraine days per month. We'll give you an acute medication. You're good to go.
Yes.
And I always tell my trainees, right? And again, for patients, we want to know about all of your symptoms on a daily basis, right? We want to know about that because it drastically changes management. So for my trainees, right, I tell them that you literally have to ask about migraine symptom days in at least 3 or 4 different ways. So as an example, you say, how many days per week or per month do you have migraine or head pain, right? And they'll be like, oh, twice a month. I'm like, okay. So twice a month, 2 days per month. That means the other 28 days out of a 30-day month, you're completely symptom-free.
Right.
Oh, no, that's 2 attacks.
Wow.
Okay, how long do your attacks last? They're about 3 to 4 days. Okay, so 4 days times 2. So 8 days out of the month, you're having migraine symptoms, right? And they're like, yes. And then I say, okay, so the other 22 days, you're completely symptom-free. Well, no. Then I have my regular headache and my regular kind of day-to-day symptoms.
Wow.
Well, tell me about those. Well, every day I have sensitivity to light, sound, smell, motion. And you know what? I actually have a little bit of a headache every day. Now that person has gone from 2 days per month to 30 days. And now that person has gone from only needing an acute medication based on evidence to needing really aggressive preventive therapy.
Wow.
Right?
I mean, that is such a vast difference.
Yes.
That is life-changing. And part of the discrimination to me is from what I'm hearing you say too, is that we've let people think that okay is okay.
Exactly.
And they need to know that like, you don't have to live like this. There are options and there are potential therapeutics that it may take time. We've talked about that over the last couple of weeks, but I think that's such a powerful message. We discussed maybe tracking it, keeping an app, keeping a calendar, whether you have a paper, no matter what it is. Would you say that sounds like that's pretty valuable to take into your physician then to say, this is pretty severe?
Yes, I think it's a great idea. And, in my clinic, I have a lot of patients with chronic migraine.
Yes, sure.
I have a lot of patients with daily headache, and they get really frustrated with diaries because they're like, you want me to tell you that I have a headache every day? Like, how is that useful, right? And
they're just checking a box. Yep, headache. Yeah.
They're like, I don't need to keep a diary. I have a headache every day, right? But what I want to know is your functional impairment.
Yes.
What has your migraine not allowed you to do?
Yeah.
Or what has your treatment allowed you to do? So I like using that stoplight diary based on function. And I like old school paper calendar, 3-color markers, paper calendar right next to your toothbrush. You do it at the end of the day every day.
Yeah.
App is fine as well. A lot of people love those apps. But really what I want to know is it a red day, meaning are you in bed and you're unable to go to work, go to school, function, take care of your kids, whatever it needs to be? Is it a yellow day where you couldn't do things as well as you wanted to, but you were able to push through the day somehow, right? Or is it a green day, which means you had very minimal impairment, right? And a lot of my patients that have daily symptoms really do embrace that because it's based on function.
It's powerful.
And it captures your attacks, it captures in between attacks, and it also captures side effects.
Yeah.
Because if I give you a medication that you say, yeah, my migraine is better, but I'm sleeping all the time, I
Right.
haven't done anything good
Right.
because you still have functional impairment as a result of your migraine disease, even if it's from the treatment
Yeah.
itself,
You
right?
think too, like I think so much about women and how we all kind of grew up in the media with she has a headache,
Oh,
almost
yeah.
a joking way or moment. And this sheds so much light on, I think about myself and my son playing baseball. And okay, maybe I couldn't go to the game Saturday because I had a migraine or I have a migraine attack, but the next day I'm feeling terrible and I'm this and this, but you have to push yourself because you're like, well, I missed yesterday, but there's still all these symptoms
Yeah.
and you're pushing through. And we're really, I think if there's the big message to me in this is it okay is not enough. Like I feel like I know we said that, but that is so resounding to me.
Yeah. So, for whatever reason, when my patients come in and I start with, so how's it going? How are you doing? So many of my patients will say, oh, I'm fine. Especially my patients that have received some benefit from treatment.
Yeah.
They'll say, oh, I'm
I
fine.
feel like they've got a gift.
I'm
Oh,
fine. Yeah,
what about her?
fine.
Yeah.
And my fellows know, like the answer that I always say to that is, well, fine is not enough.
Yes.
Right?
Yes.
So tell me what fine looks like to you, right?
Wow.
And they're like, well, I went from having 20 days per month with headache and migraine symptoms, and now I have 10.
Yeah.
And, Dr. Starling, based on the data, you told me that our responder is considered, less a 50%
Yes.
reduction, right? So I'm at goal, right?
Right.
And I'm like, well, you're at our first goal, but fine is not
I
enough,
love that.
right? We need to continue to strive for as close to migraine freedom as we can.
Yeah.
That doesn't mean a cure. It is still a chronic disease. It is present, but we do have tools that we can continue to optimize
Yeah.
individuals' preventive treatment as well as their acute treatment to get them as close to migraine freedom as possible. So I think another tip for patients and caregivers to really encourage and empower their loved ones to do when they go in to talk with their doctor is accept that fine is not enough.
I love that.
Be grateful for maybe the improvement you've made, yes, but can we do better?
Yes, I love
Right?
that.
How can we tweak things to do better? You should always really try to figure out how can we do better? And talk about what are the treatment goals? Like, okay, doc, you want me to use this medication for my attacks. What should this medication do ideally? So I tell people for an as-needed treatment option, within 2 hours, I want you to be back to your normal self. Can I get there with every patient? No, maybe I can't with the tools I have available now, but I want them to know that that's the goal.
Yes.
So
That has
until
to
we
be
get
so
there,
freeing to people. I bet you see people tear up like,
oh yeah,
like really? This is a potential, this is possible? I mean, that's amazing. I can't imagine. One thing I want to tell people too who are watching, I know we're almost out of time. We could talk about this for a while because it's so powerful. But one thing I've really heard people say is it's also okay to like change practitioners.
oh
You're
yeah,
going to a practitioner, and to me, it sounds like some of the discrimination too is educate yourself. Go in with, we have such great resources on our website. Take those resources with you. Take pieces of this and write it down and take it to your doctor. Whatever you need to do to say, fine is not enough. And it's okay to see a headache specialist. Now, I am from rural South Carolina. There are not headache specialists on every
Mhm.
corner. And what do people do about that? How do they see, like maybe they don't have great insurance. Maybe they're like, that just sounds really difficult. Do you have advice what they should do?
So I agree with you 100% that patients should never have to prove your pain to your
Wow.
provider.
Wow.
You say you have pain and you believe it. I had someone ask me that once, from a place coming from, unjust and
Yes.
stigma and discrimination, right? They said,
Yes.
so patients tell you that they have pain and you just believe them?
Wow.
And I said, yes.
That almost
100%.
hurts my heart to have to
A
think that
hundred
meds do
percent,
that.
right?
Yeah.
So yes, I agree. Um, People living with migraine, you do not have to prove your pain to anybody.
Yeah.
Um, that is 100%. If you feel like you're having to prove your presence of symptoms, whether it be pain or other symptoms that are experiencing migraine, it is likely time to change.
Yeah.
And I would also recommend it might be a good time to send a kind professional letter as to why you're leaving that practice,
I love that. I love that.
right?
Yeah.
I mean, maybe that's something that, we can provide people some tools as to what kind of language they could
Yeah.
use, right? But I think it'd be a good idea to provide that
I
feedback,
love that.
right? Now, the other thing is there are a lot of amazing healthcare professionals that are out there, primary care providers, OBGYN, as well as general neurologists, even before you can get access to a headache specialist, which is challenging. But there's a lot of other healthcare professionals that are really willing to learn from their patients.
Yeah. I
And
love
so
that.
I would recommend for patients to download those resources and bring it in and say, you know, I think I have migraine. It is a brain disease. I have these things.
Yeah.
I've heard about these treatment options and maybe I can use them. Carrie, I actually did this myself. So I have migraine. And I probably had it from when I was much younger, but it was without aura.
Yeah.
And so I never, like the 50% of people who've never talked to a clinician about their symptoms,
Right.
I was in that cohort. And when I got to college, I developed aura, and visual aura. And of course, that was very worrisome as
Yeah,
to
of
what was
course.
happening. So I went to the university health physician, and they diagnosed me very quickly. They're like, oh, you have migraine with aura. And so I was like, okay, great
Yeah. Yeah.
diagnosis. Now what do I do about it? And they said I was a double major. So they said, you're a double major, you're too stressed out. You need to drop one of your majors.
Wow.
You're also working. You need to stop working, because this is just too much for you. And you need to go get some massages and drink some more water.
Wow.
Right.
Wow.
So I was like, okay, I like my
check.
majors. I need money because I'm a poor college student and I don't have money to go get massages. So I
Wow.
walked down to the local drugstore and had bottles of Excedrin that I lived off of until I got to medical school. And when I got to medical school, I learned about triptan medications. And I went to my doctor and I said, I have migraine and I'd like to try this medication. And that was how I
Wow.
started, my triptan medication.
Wow.
And
That's
so,
amazing.
I think that there are a lot of clinicians and patients can do even more than just say, I want this medication, right? But they can actually provide resources, right? The American Headache Society has an excellent series of videos called First Contact for primary care providers to provide education about migraine and headache disorders. And clinicians will want to know that information.
Yeah. It's funny how I did not realize that how often we've heard patients say, my doctor really didn't know how to treat migraine. Like actually admittedly said, you kind of think you're supposed to know. It should be early in your med school days. But I've also heard people say
Very limited.
very limited. And so there's the thing of like, oh, we could take that over the counter. And some of the doctors haven't dug into it. And instead of saying, that's not something I'm really know a lot about, let me research, they're going, well, I think I should know about this. I mean, I've actually heard so many patients tell me that. And so it really, the encouragement today too is just empowering yourself with information. People all of a sudden say to me, what does the American Migraine Foundation do? And it is clear clinician verified resources as much it is for the patient, but taking those to your doctor can
Yes.
educate them also. Even if they don't walk off and go, wow, I've never heard this, it could be life changing because they may get back to their office and go, oh, I didn't realize this.
Yeah.
And so, thank you. Thank you for, I mean, we could literally sit here and keep talking because I want to tell people this is what headache medicine is about. It's people like you. Like, I think people go, oh, headache medicine. There's a doctor that does. Yes. And they're excited like this.
Yeah.
I wish I could show everyone the whole room. There's research. I mean, there's pages and panels of research happening. Because people often go, well, there's no cure. What's happening behind the scenes and but that it gives me chills actually to see all the research that's happening to try to help patients like those who are watching. And I just want to give them hope. And so thank you for providing that hope. Thank you for saying, hey, I'm not just gonna practice a couple of days a week and go, I'm gonna change lives. And so thank you.
Oh, you're very welcome. Yeah, I mean, headache medicine and us as clinicians and scientists, it's not just about the research, it's also about education, right? We're always learning from each other. I mean, several of my patients from last week and the last couple of weeks, I'm like, okay, we have tried a lot of different things, but I'm going to the American Headache Society meeting and I'm going to go to all the talks about cluster and I'm going to figure out what are the new things that my other colleagues are trying, and let's figure out how we can apply them.
Right.
So we're all still learning. We're doing tons of research. We have a lot of tools that are available, and we need to figure out how to disperse those tools to the right people so they can get to the patients. But we also want to provide that empowerment and hope to patients to know that we're here.
Yes.
And we're working hard, and we have these resources, and we want you to go to doctors and say, like, if I'm not getting the treatment that I need, if I'm not getting the care that I need, can you learn about this? And if they're really resistant to that,
it's okay.
It's time to move on.
Doctors. Yeah, I
it
love
is.
that. Thank you so very much. Thank you for your heart and passion. She is as legit as you see. Like, there is passion, there is drive to change patients' lives. So thank you so much. And we also want to thank our partners, Lundbeck, who sponsored this week on discrimination. And it's one of their core values that they want to make sure everyone gets help and everyone gets what they deserve as far as being not okay, but just being fine. So thank you. Thank you so much. Thank you all for watching. We have more to come next week. It's the last week, but we've got some exciting stuff then too. So thank you. Enjoy your conference and go just keep learning. Keep learning and teaching all of us.
Bringing it all back.
Bringing it back. So thank you.
Sure. Thank you.
Have safe travels back too.
Perfect. Thanks.